So in 2018, there was the Hotline Improvement Act that brought the VA, SAMHSA, and FCC together to identify a 3-digit number for the suicide lifeline. That 3-digit number was 988, and it went live last July, so that when you call 988 anywhere in the country, it forwards to the 1-800 number that existed for the suicide crisis lifeline. And they've added crisis into it as they are starting to build out the crisis system for our country. First, they're building out improved resources for crisis centers across the country to answer 988 calls. The calls are routed by the area code of the caller to a local crisis center through that 1-800 number. And when they answer, the idea of routing it locally is so that that local center can provide local crisis resources. Most of their calls are resolved on the phone, providing 24/7 compassionate care over the phone for somebody who is thinking about suicide or in crisis. About 2% prior to the rollout of 988 of calls were referred for an emergency response. What's really important is as SAMHSA builds out the next phase of this crisis system across the country, is they're going to improve access to mobile crisis in communities and start working on building stabilization centers. EMS needs to be at the table at the state level as they build out 988 implementation and this new crisis system. Right now, we are the safety net system. If there is an issue that they need a response, 988 works on identifying the correct 911 center to dispatch resources. So we already are doing some of this function. The goal is for us to be interoperable with these systems that SAMHSA and the crisis community are building. So at the state and local level, each state's going to do this differently, and each state is going to oftentimes be receiving grant funding from SAMHSA to help with implementation of this expanded crisis system. EMS needs to be engaged at the state and local level with 988 implementation and the crisis systems and the resources that are being built out. Because if they silo and they build a 988-based crisis response team that's dispatched by 988 and they don't involve 911 or EMS, then we're going to have two parallel systems. All of our communities need more crisis resources. Our EMS systems need more opportunities to give our patients the right care at the right place, the right time. So if we can collaborate, then we can build out a system that's interoperable, and potentially EMS can work on leveraging funding through local, state, and maybe even federal crisis funding for co-responder models or other ways that they can do mobile crisis collaboration as they build out this crisis system. First, I would really encourage you to know who runs your crisis center in your community, in your state. And then at the federal level, there's a 988 website run by SAMHSA, and all you have to do is Google it and you'll be able to find it. And that'll give you the federal plan. But recognizing that most of this money is going to come to the state and then be distributed and utilized by the state, this is a time to really be engaging your behavioral health resources in your community and at the state level. I think it's really important for us to recognize that oftentimes we don't want to have to take extra training, have to do extra work. This isn't us trying to take on somebody else's work. This is us trying to be interoperable so we have opportunities to leverage their resources when it's appropriate and for them to leverage our resources when it's appropriate. But to do that, they have to understand our system. We have to provide them with that education. And we have to take the time to learn about them and learn about what they're building, how they work, and how they do their work so that it's mutually beneficial and we understand each other and trust each other.
Kate Elkins from our National Office of EMS, thank you very much indeed.
Thank you.